So I'm going to go through actually the ISWAG practice guidelines to highlight what they recommend, and I'll add some to that of what a normal four-chamber view is. So first of all, understand that it is an axial plane, a transverse plane, typically at the level of the fourth thoracic rib. And you have to see one full rib on each side. That's your guide to know that you are in a perfect axial plane. Sometimes you get a little bit off, and you see multiple cross-sectional ribs. Always readjust to get to the four-chamber view. Now, the first thing to look at, typically, sometimes I get asked, what makes a four-chamber view normal? So it's not only to find two equal ventricles and two equal atria and maybe a normal axis. There need to be a lot of things that you need to go through to make that four-chamber view normal on your evaluation. And I'm going to go through this list during this presentation. First, the situs of the fetus, right? So identify which is the right side, which is the left side, and make sure that the stomach and the heart are on the correct anatomic side, the left side. So I always start with the abdominal circumference plane, an axial plane at the level of the stomach. This is what we use to measure the abdominal circumference. So if you bisect this plane into two halves, as you see here, the descending aorta should be on the left side. The IVC should be on the right side, slightly more anterior at that level in the abdomen than the descending aorta. Stomach on the left side, gallbladder on the right side. So these are the things I would look for. And as we will talk later this afternoon, the portal sinus, or the curvature of the umbilical vein as it comes in, should point towards the right side, as you see in the schematic drawing here. So in the four-chamber view, again, determine the situs. Once you've done the situs at the level of the abdomen, I slide up to the chest to make sure that the descending aorta is to the left side of the spine, and to make sure that the four chambers are displayed as you see here. Again, a large segments of individual ribs are seen on each side. Why is situs important? Because situs abnormalities could be a clue for you to the presence of other associated congenital heart disease and also some abdominal abnormalities. So a normal situs, solitus in Latin is normal, for those of you who took Latin in college. So the right atrium is morphologically a right atrium. Most of the liver is on the right side. Inferior vena cava is on the right side. The right lung has 3 lobes. And forget about that. This is how the bronchus of the right, whether it's related to is epiarterial or hypoarterial. But this is something we don't see on ultrasound. The left atrium is a morphologic left atrium, meaning that the atrial appendage is narrow. The stomach is on the left side. Descending aorta is on the left side in the chest and the abdomen. The left lung is bilobed. In inversus, it's a mirror image of these two. And these are the ones that tend to be missed prenatally, because you'll have the stomach and the heart on the correct side, but they're on the same side, but they're on the right side. So go into the habit of determining where the left side is first before you look and see whether the stomach and the heart are on that side. And situs ambiguous is when things are variable. So why this is important again? Because situs ambiguous has a significant increased risk of congenital heart disease. We're going to have a talk on heterotaxy that will go through this in details. Situs inversus, on the other hand, is rarely associated with congenital heart disease. The incidence is slightly increased. It appears over the background risk. But there's about 20% risk of a syndrome called Cartagena syndrome, which is a significant syndrome that involves cilia abnormalities in the fetus, that results in some GI abnormalities, lung abnormalities, and male affected with this syndrome are typically sterile after birth. So there is an implication to a situs inversus, and this is why it's really important to look for that. At the level of the abdominal circumference, here's an example of left isomerism, or double left-sidedness, if you will. Note that these are two separate fetuses with left isomerism. See that the stomach is on the left side here, and the stomach is on the right side here. So the location of the stomach really has no bearing on whether this is left or right isomerism. Always look in about 75% of left isomerism. The IVC does not develop above the renal veins, and you have an agenesis of the IVC, and the blood returns to the heart through the azygous vein. So when you look at the cross-section, you see that the azygous vein is enlarged, should be about a third the size of the aorta. Here you see it almost the same size of the aorta. Whereas in right isomerism, as you see here, again, stomach on the left side here, stomach on the right side, there's two separate fetuses with right isomerism, but the IVC and the aorta tend to be on the same side, typically the left side, and as you see right here. So it's important to remember that the stomach really has no bearing on your diagnosis, but look at the great vessels in the abdomen. That's a very simple and important plane to assess what kind of isomerism you have. As stated, situs ambiguus has a lot of abnormalities, not only in the heart, but venous drainage in the abdomen, malrotation of the bowel, bronchial tree abnormalities, and so forth. Always look at the gallbladder too. That could be a clue to the presence of biliary atresia in those cases. So as you start the four-chamber view, you look at the laterality of the fetus, determine where the stomach and the heart. Then the next step is to make sure that the heart occupy about a third of the chest, and the majority of the heart is in the left chest. So what you look, subjectively, you assess what the size of the chest is and the size of the heart. That should be about a third here. So you should be able to fit two other hearts easily in the chest. If not, you think about cardiomegaly, and we'll talk about the implications of cardiomegaly throughout these 2.5 days. There are some ratios, the cardiothoracic ratios or heart circumference tables you can use to give you more objective assessment of the size of the heart, and most ultrasound systems have those in them. And also that the heart should be about 2/3 of it should be in the left side of the chest. So if you bisect the chest into two halves, only the right atrium should be on this side. Now, there are hearts that are pushed a little bit right on left. These are typically normal variants without much implications, but in general, this is what you need to see. Next, you look at cardiac position. Where is the heart in the chest? The normal position is in the left chest, right? But that's levocardia. But within levocardia, there's some abnormality. So the heart could be further pushed to the chest if you have a right chest mass that pushes the heart in the chest. Or the heart could be in the right side of the chest. Then there are two terms here to know. Dextroposition, meaning that the heart is pushed to the right chest and the apex still points to the left side. Dextroversion is kind of like a situs inversus type, where the heart is in the right chest and the apex is pointing to the right side. Mesocardia is when the heart is in the central portion of the chest. So let's look at some examples. Here's a levo position. Heart is pushed more because of a right chest mass. Here's a dextro position. So there's a left pleural effusion that is pushing the heart to the right side, but the apex still points to the left. Dextrocardia is kind of like the situs inversus type, where there's a mirror image. The apex here points to the right side, and mesocardia is when the apex of the heart points to the middle of the chest. So remember, even though the four chambers are normal and the size of the heart is normal, this is an abnormal four-chamber view, and you need to investigate further. So you need to meet all these criteria before you make a determination that the four-chamber view is normal. So here's examples of what causes dextroposition. Scimitar syndrome is agenesis of portions of the right lung. And here's two cases recently that we have. They both are pulmonary sequestrations, but you see there's a left-sided mass. You can see some normal tissue here, and it's pushing the heart to the right side, but this is dextroposition because the apex still points to the left side. And here's another case with a sequestration down here on the left side, and the heart is pushed to the right side, but the apex still points down. Causes of dextroversion, the most common is situs inversus, but situs ambiguus, as stated, or discordant atrioventricular connections, and we'll have some discussion about that later in the course. Mesocardia is a rare position of the heart in the chest, but it's commonly associated with transposition of the great arteries or with double outlet right ventricle. And also, if you have laryngeal atresia, both lungs are inflated and they compress the heart in the middle. Certainly pleural effusion. This is a case of pleural effusion on the left lung, as you see right here, that pushed the heart to the right. But here's what's the middle of the chest, and you see that's a mesocardia. The apex is almost centrally located in the chest. So keep those in mind, understand where the heart is and what could cause the shift of the heart position in the chest. Next is looking at the cardiac axis. So subjectively, the heart should be in an axis of about 45 degrees. So here's you bisect the chest into two halves. You draw an axis through the long axis of heart. This angle should be about 45 degrees. Plus or minus 20 is the normal range. So this has been determined back in the 80s through work in Boston, what the normal cardiac axis is in the second trimester. And you see that it does not change with advancing gestation, so it's constant throughout gestation. And actually, we'll show you when we talk about the first trimester that even at 11, 12, 13 weeks, the cardiac axis is the same. And here are cases with congenital heart disease, and you see that most cases will show a left axis deviation when there's congenital heart disease, similar to what we see in the first trimester. Here's some examples. So here's a common arterial trunk. Look at the apex of the heart, almost 90 degrees here. Tetralogy of Fallot, again, if you bisect the chest, almost a 90-degree angle. Here's the normal axis. And here's mesocardia in a case of transposition of the great arteries. Look where the heart is, in the center of the chest. And here's a double outlet right ventricle. The spine is here. So again, it's almost a mesocardia heart. So looking at the heart, also learn to recognize the cardiac axis and the association with cardiac axis abnormalities. So once you've done all this, then you start looking at the chambers themselves, trying to figure out whether they're normal or abnormal. So that's what the four-chamber view should look like. Here's what we call an apical four-chamber view, meaning that the ultrasound beam is entering the chest from the apex of the heart. These are good to look at the outflow tracts, especially the left and right outflow tract, and looking at this portion of the septum for inlet VSDs. Here's what we call the axial or the long axis. Here, the ultrasound beam is perpendicular to the long axis of the heart. Very important, again, to look at the LVOT, but also to look at the muscular part of the septum and the perimembranous part of the septum, where the ultrasound beam is perpendicular to the long axis of the heart. And here's what we call a basal four-chamber view, where the ultrasound beam comes in from the right shoulder, enter the atria first. Good to look at the septum primum area here, look at the atria, and also look at the pulmonary drainage here, as I'll show you in a minute. The advantage for us is that you can probably get 2 out of 3 every single time. By going perpendicular on the maternal abdomen, you can get a basal and an axial, or an apical and an axial in every patient. So learn to look at the heart from different angles, because it provides you different information. So atrial chambers, 2 atria should be almost equal in size. Foramen ovale should flap from right to left. Important finding is we'll see with various anomalies that get discussed in the next 2 days, that could not be the case, and that allows you to assess severity of the anomaly you're looking at. The septum primum area is present. We'll talk about AVSD today and the importance of that, and the pulmonary veins entering the left atrium. Very, very important. We'll have a lot of discussions on venous anomalies in the next 2 days. So the left atrium is the most posterior chamber. It anchors the heart to the chest through the 4 pulmonary veins that enter posteriorly. And the left atrial appendage is small and narrow, is very different than the right atrial appendage, which is broad. So in cases of isomerism, that could help you determine the morphology of the atria. So what you look for when you look at the left atrium, really you should pay a lot of attention to that area behind the heart. So here's the spine right here, descending aorta. Here's the esophagus that is closed, appears like an echogenic, like a structure right here. And here's the 2 pulmonary veins. At the level of the 4-chamber view, the 2 inferior pulmonary veins enter the back wall of the left atrium. The 2 superior pulmonary veins are seen in the LVOT plane, which is a little bit higher up. Very important area to look at, because of the significance of this anatomic region in the back here, because when we talk about anomalous venous return later on, you'll see how important that structure is to look at. Now, keep in mind that the esophagus is there, and when the baby swallows, the esophagus would appear like another vessel that is sitting between the descending aorta and the back wall of the left atrium, as you see in this fetus right here. The advantage of this is that it opens and closes within seconds. So if you monitor just long enough, you will know that this is the esophagus, and this is not a collector vein, for instance, sitting there in an anomalous venous return. Very, very important structure, keep in mind. To look at the pulmonary veins, you have to reduce your velocity scale. So if you start your exam in your cardiac presets, you may have difficulty seeing the pulmonary veins. So you increase your gain and reduce your velocity scale to see the pulmonary veins coming in. And here you see 2 on each side because we're at very low velocity scale. And look that you need to be parallel to the direction of blood flow in the pulmonary veins. Here's another example here. You see that the ultrasound beam is coming parallel to the veins to show you the direction of blood flow. We're going to have a lot of discussions on this. Just to show you the importance of this is in the types of anomalous venous return, they all have this confluent vein that sits behind the left atrium. And it's really important as part of the 4-chamber view to make sure there's nothing like this behind the left atrium. The right atrium is anteriorly located. It receives the SVC, IVC, and it have the foramen ovale in there and has the opening of the coronary sinus. Remember that the SA node and the AV node both are located within the right atrium. So diseases that result in right atrial enlargement, such as Epstein and others, are associated with rhythm abnormalities because of that. So the crista terminalis is that structure in the heart that plays an important role in directing blood flow coming from the IVC with the oxygenated versus deoxygenated blood. This is where, in the rare occasion that we saw this, I wanted to share with you that the right atrium here, where you see that structure inside. And this is it on still image. Remember that the right atrium receives the coronary sinus, and the coronary sinus is seen in a plane that is slightly posterior to the 4-chamber view, and it appears as a structure right here that comes in like halfway and then opens into the right atrium at this level. This becomes really important when you're looking at, either an umbilical vein that's emptying into coronary sinus, or anomalous venous return, or an LSVC. So looking at the coronary sinus becomes an important part of your evaluation of cardiac anatomy. The sagittal view shows you the right atrium in this sagittal view. Here's the right atrial appendage. You see how broad it is. And here you see that Eustachian valve, the IVC and SVC coming into the right atrium. So septum primum, septum secundum are really important to evaluate, especially for atrioventricular septal defect, and we're going to have that discussion, I think, later on today. So in assessing the ventricular chambers, 2 ventricles that are almost equal in size, no ventricular wall hypertrophy. The moderator band is an important anatomic feature of the right ventricle, should be at the apex of the right ventricle, and the septum should be intact from apex to crux. Right ventricle, remember that the inlets of the right ventricle and the apical region are trabeculated, whereas the outlet is smooth. The inlet and outlet are in different anatomic planes, unlike the left ventricle. The left ventricle, the mitral valve and the aortic valve has fibrous continuity, so they are in the same plane, whereas here on the right ventricle, the inlet and the outlet are in different planes. The outlet is superior, is higher than the inlets. Tricuspid valve has 3 leaflets. Very, very important. The septal leaflet of the tricuspid valve is more apically inserted on the septum than the mitral valve. As you could see in normal anatomy, this is a very important feature that helps you ruling out AV, ST, and things like that. And here's an autopsy specimen showing you where the insertion of the septal leaflet of the tricuspid versus the mitral valve here. Also, what's important to note is that unlike the left ventricle, the right ventricle has direct chorda tendineae insertion to the septum of the ventricle. All the chorda tendineae in the right ventricle inserts into the support structures, whereas in the right ventricle, there's free chorda tendineae that inserts in the wall. You'll see it in an axial plane like this. That helps you to determine the morphology of the right ventricle as opposed to the left one. The left one is conical in shape. The valve, the mitral valve, is bicuspid. There's close anatomic relationship to the inlet and outlet as stated between the mitral and aortic valve. There's 2 papillary muscles, and all the chorda tendineae inserts into these 2 papillary muscles on the left side. The right side, some chorda tendineae inserts straight into the wall, and as stated here, ventricular wall receives no chorda tendineae insertion. So conical in shape, and it's apex forming. Both in the fetus and adult, the left ventricle forms the apex of the heart. That is lost in hypoplastic left heart syndrome and any congenital heart disease that makes the left ventricle smaller. As you see right here, that's what is meant. And you see the papillary muscles here with the insertions of the chordae tendineae. On cross-section, going from the bottom of the heart up towards the valves, you see the left ventricle here with these papillary muscles right here. Here's the right ventricle. As you move up into the valves, look that the valve of the left ventricle is mitral, is kind of like a more ellipsoid in shape, whereas the tricuspid valve is more circular in shape. In ventricular septum, again, there's a muscular and a membranous component. We're going to have a talk on AVSD, so we'll talk about how to evaluate the septum looking at muscular or perimembranous ventricular septal defects. So once you've assessed the ventricles and the atria, you look at the AV junctions and valves. There should be an intact central portion of the heart, 2 AV valves open and move freely. It's really important to get into the habit of freezing your clip on the 4-chamber view and cine-looping slowly to look at the valves and look at the central portion of the heart. It's really important. It improves your visualization of any abnormalities, allows you to assess the relationship of the valves and the central portion of the heart. Just to remember that the valves, the mitral and tricuspid are in the same level. The aortic valve is in the central portion of the heart, and the pulmonary valve is the most anterior valve. Relationship of the valves as stated, septal leaflet towards the apex more than the mitral valve insertion. Systole and diastole, it's important during diastole you look at the central portion, make sure it's intact, make sure that the valves, there's no VSDs or ASDs here, and the valves are normally related. So once you've done all this evaluation, you also have to look at the rhythm of the heart, and you do this subjectively by looking at the heart, looking at the atria and the ventricles. Learn to look and see that they are contracting rhythmically between the atria and the ventricle. We are going to have a talk today on rhythm abnormalities in the heart that you can really suspect by looking at a 4-chamber view. And then you have to make sure there's no pericardial effusion around. So here's a normal 4-chamber view. There's always a little bit of pericardial fluid, as you see right here. And here's a little bit more than you want to see in this normal fetus, otherwise saw this recently. And you measure, there's some 3-millimeter cutoffs and things like that. To me, it's more of a subjective assessment whether there's excess fluid or not. Typically, the pericardial fluid is surrounding the heart, so you see it on both areas, whereas pleural fluid tends to be on the outside. So in looking at the 4-chamber view, remember to go systematically in assessing the size of the heart and going down from situs, size of the heart, access, location in the chest, into the atria, ventricles, rhythm, fluid, and so forth. Also remember that there are a lot of abnormalities that we'll be discussing primarily today that are associated with an abnormal 4-chamber view. However, there's a long list also that may have either a normal 4-chamber view or what appears to be a normal 4-chamber view. Here are 3 cases that I will show you tomorrow, tomorrow when I talk about tetralogy and others that are perfectly normal 4-chamber view. 2 of them are associated with tetralogy of Fallot, and this one with transposition of the great arteries. So it's really important to understand that a 4-chamber view alone is not sufficient screening for congenital heart disease. The basic obstetric ultrasound exam is being revised today, and we will have in it not only the 4-chamber views and the outflow tracts, but also the 3-vessel trachea view, which we will talk about in more details during this course. So 4-chamber view, normal size heart and chest, transverse plane of the chest with 1 complete rib on each side, descending aorta in front and to the left of the fetal spine, apex of the fetal heart pointing to the left upper chest about 45 degrees, atria equal in size, foramen ovale opening in the left atrium, 2 inferior pulmonary veins seen in the posterior wall of the left atrium, patent AV valves, tricuspid valve septal leaflet more apically inserted on the septum then the mitral valve, ventricles equal in size and contractility. It's really important to subjectively assess the contractility of the heart. It is probably as relevant as doing cardiac function studies on the heart. Intact ventricular septum and the moderator band in the right ventricular apex determining morphologically the right ventricle. So keep in mind that a 4-chamber view is normal when you meet all these criteria, and make sure that as you do your ultrasounds, you need to look comprehensively at all these features to make a 4-chamber view normal.